Biological and clinical basics of orthopedic treatment by partial removable laminar dentures. Laboratory procedures. Guided by Associate Professor, M.D., Ph.D., Vyacheslav Tomilin. Plan of the lecture. 1. Introduction. 2. Indications and contraindications for partial removable laminar dentures, PRLD, manufacturing. 3. PRLD structural elements, base, clasp, artificial teeth. 4. Partial removable laminar dentures laboratory procedures. Introduction. Topical issue of prosthetic dentistry is a clinical and biological substantiation of necessity of orthopedic treatment of dentition's defects. Violation of the integrity of dentition, an irreversible process. Restoration of them is possible with the help of dental prosthetics only. In order to properly of the body function need adequate and nutritious food, complete absorption of nutrients, vitamins, minerals and microelements, the normal enzymatic activity of the gastrointestinal tract. Partial removable laminar dentures, PRLD, in edentulous patients allow restoring teeth loss and underlying tissues. Manufacturing of PRLD is carried out without damaging of the abutments. PRLD restore mastication, aesthetics and can be easily removed for cleaning. On the other hand, PRLD, with wire-bended clasps, can restore the effectiveness of mastication not more than 60%, Beetleman A.I., 1965. Transduction of masticatory load on the mucous membrane of oral cavity leads to atrophy of the bone under the PRLD's saddle. Furthermore, PRLD's saddle breaks tasty, tactile, temperature sensitivities and decreases the self-cleaning of mucosa. However, PRLD are very popular in dentistry. Following the indications for PRLDs and manufacturing technique ensures the successful result of treatment. In deciding on the denture design, consider cosmetic and phonetic demands on the one hand and restoration of the functional value of the masticatory apparatus, on the other. The absence of a large number of teeth. Excessive load on the abutment teeth makes questionable functional value of fixed prostheses. Jaws deformations. The distortion of facial contours due to the loss of a large number of teeth, retraction of the lips and cheeks, indication for treatment by PRLD. With a removable denture, you can eliminate these defects. Large extent on the defects of dentition, located between the abutments. With high sensitivity to the presence of a foreign body in the mouth, with a total nervous disorder adaptation to PRLD is longer. The aesthetic effect plays a significant part in prosthetics, preference is given to the prosthesis, less catches the eyes. Contraindications to orthopedic treatment of dentition defects with partial removable laminar dentures are divided into absolute and relative. In the first case, it is impossible to use prosthesis due to the impossibility of changing the general somatic state of the patient. This is observed in schizophrenia, epilepsy, refractory dental pathologies, individual intolerance to the material of the prosthesis. In the group of relative contraindications for wearing a removable structure: bite pathology, tuberculosis, actinomycosis, periodontal disease, infections, acute inflammatory processes, rehabilitation after a stroke, heart attack, exacerbation of a chronic disease. In the latter cases, the construction can only be worn after the transition has recovered or entered the remission stage. Design features of partial removable laminar dentures. The length of the dentition defect in 2 teeth located in the posterior area and 4 teeth in the anterior area. Dentist applies bridge-like dentures. In other cases, the dentition defects are replaced by partial removable dentures. The main masticatory pressure occurs in chewing put on the bone of prosthetic seat area foundation. Depending on the method of fixation and character of the pressure redistribution between abutments during chewing process and prosthetic seat area tissues, the dentures are divided into laminar and clasp. All laminar prostheses consist of an acrylic base, supported on alveolar bone, on the body of the jaw, artificial teeth, restoring the integrity of the dentition, and clasps that hold the prosthesis on natural teeth. This picture shows principal components of partial denture and partially edentulous lower jaw. 1. Acrylic base. 2. Artificial teeth. 3. Holding elements, wire-bended clasps. According to V. Nkapikan and L. M. Demnor, 1985. Denture base. Acrylic base, basis, of the laminar removable prosthesis is a plate made from plastic or metal, on which are mounted artificial teeth and devices to hold the prosthesis in the mouth. Acrylic base is an area of a denture made from acrylic resins to which the artificial teeth and holding elements are attached. Acrylic base covers the alveolar ridge in the jaw's body. On the upper jaw it also covers the hard palate. It should correspond to the relief of hard palate precisely. With acrylic base the masticatory load from teeth is transferred to the mucosa. The dimensions of acrylic base depend on the amount of preserved teeth, pattern of missing teeth, shape of alveolar ridge and hard palate's arch, degree of residual ridge's atrophy, condition of underlying mucosa and size of torus. It is known the more dimensions of acrylic base, the more load is applied on the underlying tissues. That is why the more missing teeth the more surface of acrylic base should be. The maximal borders of PRLDs are shown on the picture. On the buccal and labial surfaces of upper and lower jaw's residual ridges the border is located with receding of 1 to 2 mm from superior vestibule. The border also should avoid the area of frenums. In lingual surface of lower jaw the border of PRD extends to fold with receding of frenulum of tongue. Borders of PRLD on the upper jaw and lower jaw. On the hard palate the distal border extends to line A. This line passes through the palatine fovea which locate between soft and hard palate. Maxillary tuberosities are also covered with denture. Remaining teeth are covered up to the 2/3 height of clinical crown from lingual surface, but in frontal teeth acrylic base should just adjoin the teeth necks. If median palatine raphe and lingual tori are strongly pronounced, they should be marked on gypsum models for further isolation. Acrylic base of PRLD is made from special base acrylic resins. Acrylic base of PRLD is made from special base acrylic resins. Base disadvantage. Covering the hard palate the base to bring on violation of tactile, taste, temperature sensitivity. At the same time there may be a violation of speech, self-cleaning of the oral mucosa, her irritation, sometimes the appearance of the gag reflex. In places fit the prosthesis to natural teeth gingivitis can occur with the formation of pathological pockets. Prosthetic dentistry plastics. Plastics for dentures bases have different shades of pink color, which is determined by the color of the starting powder, Adacryl-02, Ftirax, or the number of injected coloring agent, Acrin. Available as colorless plastic base, which use in patients with allergic to the coloring agent, for the manufacture of dental alveolar clasps in order to obtain the aesthetic effect. Adacryl-02. Indications for use. Manufacturing of complete and partial removable denture bases. Strong points. Beneficial cosmetic effect due to denture translucency and introduction in material of streaks that imitate soft tissues of oral cavity. Introduction of oligomer in the liquid allows to reduce the residual monomer content. Prolonged time of molding mass pot life. High degree of molding mass elasticity provides high accuracy reproduction of denture shape. Application instructions. Powder-liquid ratio should be 2:1. Molding mass should be maintained in plastic state for 30 minutes. Carry out the process of polymerization in water bath or in a heating cabinet at gradually increased temperature up to 100 to 115 degrees Celsius within 40 to 50 minutes. Flask should cool down on its own. Treat and polish dentures after they are cooled down. Complete set. Powder, 300 grams, 2 packs. Liquid, 150 milliliters, 1 vial. Application instruction. Thorax. Indications for use. Manufacturing of complete upper and lower jaw dentures. Manufacturing of partial dentures. Strong points. High accuracy shape reproduction. High ultimate flexural strength. Optimal elasticity. Beneficial cosmetic effect due to denture translucency and introduction of streaks that imitate the soft tissues of the oral cavity. Good polishing ability. Application instructions. Mix powder with liquid in 2:1 ratio. Plastic modeling phase is about 20 minutes. Carry out the polymerization process in a water bath and dental flasks, by bringing the water bath to boiling point gradually within 40 to 50 minutes. Polymerization process takes 30 minutes. Do not retrieve the denture from the flask until it is cooled down completely. Complete set. Powder, 300 grams, 2 packs. Liquid, 150 milliliters, 1 vial. Application instruction. Colorless plastic indications for use. Complete upper and lower jaw dentures manufacturing in cases when colored bases are contraindicated. Strong points. Plastic material contains an aging retarder. Plastic material has high strength properties. Plastic material is transparent. Plastic material provides for high accuracy shape reproduction. Application instructions. Powder-liquid ratio should be 2:1 respectively. Molding time is about 30 minutes. Carry out the process of polymerization in dental flasks at the temperature being gradually increased up to 100 degrees Celsius within 50 to 60 minutes. Polymerization time is about 30 minutes. Cool the flask down to room temperature. Complete set. Powder, 300 grams, 2 packs. Liquid, 150 milliliters, 1 vial. Application instruction. Denture base has the following maximum borders on the upper jaw. Denture base lies on the alveolar process and hard palate and must exactly match to the macro and micro relief prosthetic seat area tissues. The borders of the partial removable denture bases are located only within the competence of the passive movable tissue. On the buccal and vestibular sides, toothless areas of the alveolar process takes place on the border of the prosthesis 0.5 to 1 mm below the mucogingival junction, avoiding the movable buccal alveolar strands of mucosa and lips frenulum. The distal prosthesis edge does not reach the vibration line, line A. Maxillary tuberosity must necessarily overlap by prosthesis. This is an essential condition for the fixation and stabilization. According to presented teeth, the denture base location has the different positions in frontal and buccal side. In orthognathic bite, the frontal teeth overlap by basis on the thickness of the wax base plate, 1.8 mm. In deep bite, this area completely release from denture base. It is prevention of gingival papilla damage. Lateral teeth overlap denture base to 2/3 of the height of their crowns, which prevents immersion into the underlying tissues and delamination. The gingival margin in the cervical area of natural teeth helps to stabilize the prosthesis and the transfer pressure to the teeth. In expressed torus of the hard palate must be exclude contact of the denture base with mucosa for injury prevention. For this purpose, on the inner surface of the denture base is created the insulation camera depth of 0.5 mm. The edges of the base should have a rounded shape. When defects 1, 2 and 3 classes or subclasses by Kennedy can change the size and shape of the bases. At increased gag reflex, when included in the design of the support retaining systems, in some cases the bases border finish from in front or in the middle third of the hard palate. For professional reasons, lecturers, artists, speakers, musicians, etc., as well as increased pain sensitivity in the incisive papilla, is advisable to reduce the area in the anterior part of the basis. On the vestibular sides, toothless areas of the alveolar process takes place on the border of the prosthesis 0.5 to 1 mm above the mucogingival junction, avoiding the movable buccal alveolar strands of mucosa and lips frenulum. Denture base overlap the posterior teeth to 2/3 of the height of their crowns, which prevents immersion into the underlying tissues and delamination. The gingival margin in the cervical area of natural teeth helps to stabilize the prosthesis and the transfer pressure to the teeth. The lower border of the dental base from the oral side overlaps the internal oblique line and passes through several folds higher than the transition, with the release of portions corresponding to the place of attachment of tongue frenulum. Disadvantages of the partial removable laminal dentures basis have caused a natural desire to reduce its size and the lower jaw. These options are limited. On the upper jaw, basis is reduced primarily in the posterior third of the hard palate, where it could be the cause of the vomiting reflex. In the presence of palatal torus and the impossibility of its isolation in the base cutout window in the middle of the hard palate area. This frees up land, always covered with thinning mucous membrane, is very sensitive to pressure. Different options for reducing the basis of the laminal dentures basis with unilateral terminal defects. A. Basis shortened in vibration line, line A, area. B. Opened area in frontal teeth area. C. Opened area in frontal teeth area and partially in posterior teeth area, on the opposite side of the defect. D. Denture with mesiodistal grip wire clasp. Reduction options of prosthetic basis boundaries with bilateral included defects. A. Basis shortened in the posterior palatal area. B. Basis shortened in the frontal and back areas. C. Basis has a maximum value, but released torus area. Constructing border basis, it is necessary to take into account that it can provide a good fixation and stabilization of the prosthesis without any mechanical devices, in particular due to the anatomical retention. Retainers, holding elements of partial removable laminar dentures in oral cavity, CLASP, is a part of partial removable laminar denture which provides its fixation and stabilization. Types of CLASPs. 1. According to materials, metal, plastic, combined. 2. According to the site of fitting, to teeth, to gingiva, both to teeth and gingiva. 3. According to cross-sectional form, round, semi-round, band. 4. According to connection with a tooth, with single arm, with double arm, twin, ring clasp, multiple, unit clasp. For partial removable laminal dentures, fixation and stabilization wire-bended clasps are often used. They are made from stainless steel 1CR18N9T. Special prefabricated products can be also used for wire-bended clasps making. Their diameter is 0,5 to 1, 2 mm and one end is flattened for better fixation in acrylic base. Orthodontic wire with diameter 0,6 to 1, 2 mm is also used for wire-bended clasps making. The number and position of clasps depend on the amount of preserved teeth, pattern of missing teeth, etc. Depending on the number of clasps, dentures fixation can be classified as spot, point, lineal and plane. In spot-type fixation, only one clasp is located on a single tooth. This type of fixation provides minimal stability of the denture during its function. In lineal-type fixation, two clasps provide stability. It is best to use plane fixation with 3 or more clasps in the denture during its function. Clasp, fulcrum, lines. Imaginary line through the teeth on which holding elements are located is called the fulcrum line. In lineal-type fixation, two clasps provide stability and they may locate transversally, 1, sagittal, 2, or diagonally, 3. Types of fulcrum lines are shown in this picture. The most favorable location of fulcrum lines in upper jaw is diagonal, in lower jaw, transversal. The less favorable location is sagittal. Sagittal fulcrum line location is used in absence of other opportunities. Plane fixation of partial removable laminal dentures. It is best to use plane fixation with 3 or more clasps in the denture. It can in the form of a triangle, 1. Trapezoid, 2, and irregular quadrilateral, 3. Retainers. In partial removable laminar acrylic dentures, most widely use the round wire bent retaining clasps. Different types of retaining and supporting retaining clasps are shown in this picture. 1. Wire single arm clasp, 2. Wire double arm clasp, 3. Wire loop-shaped double arm clasp, 4. Single arm approximal clasp, 5. Double arm approximal clasp, 6. Belt clasp, 7. Gingival clasp, 8. Dentoalveolar clasp, 9. Supporting retaining cast clasp, 10. Wire supporting retaining clasp, 11. Bund wire clasp, 12. Ray-Hellman clasp, 13, 14. Mesiodistal grip clasps, 15. Continuous clasp connected together at the ends with supporting retaining clasps. Retainers. The surface of the tooth on which clasp will be located, abutment tooth, is divided in 4 quadrants. These quadrants are formed by the intersection of 2 lines, one line in the widest part of the tooth in horizontal plane and another line in the widest part of the tooth in vertical plane. The numbering of the quadrants begins in the side with missed teeth. 1 and 2 quadrants are called occlusal, also supporting in functional aspect. 3 and 4, gingival and retentive correspondingly. Supporting, 1, 2, and retentive, 3, 4, teeth quadrants, by Abelmasolv Ng, 2000, are shown in this picture. Retainers. Holding clasp is composed of 3 main elements. Shoulder, 2.1. Body, 2.2, and process, 2.3. Position of a wire-bended holding clasp on the abutment, 1. And main clasps elements, 2. Retainers. The shoulder of wire-bended holding clasp is located in 3, 4 in 1, 3 or 4 quadrants. Shoulder covers supporting tooth, abutment, from the vestibular side and provides maximal contact with tooth. Clasp should be passive, put no active force on a tooth in rest state. It should also provide elasticity during function and do not cause a trauma of soft and hard tissues. Body is a part of a clasp that is connect shoulder with process, Fig.2.2. The body is located on a proximal tooth surface a little bit above the contact area, closer to occlusal surface and slightly below it. The clasp's body has a loop-like bend and serves as a shock absorber during function of the shoulder. The clasp's body should be free from denture base material. In frontal group of teeth, because of aesthetic reasons, the clasp's body is located close to gingival margin. Process is a part of a clasp, which is helped to hold it in denture's base, Fig.2.3. Process is located along the edentulous alveolar ridge, under artificial teeth, in plastic denture base, with stepping back 1 to 1, 5 mm from the surface adjacent to the mucosa. The end of the process has to be flattened or like loop bended in order to avoid process rotation during denture's function. Artificial teeth. All artificial teeth used in modern prosthetics differ in material from which they are made, the method of fixing a denture base and the location in the dentition. For partial removable laminar dentures, resin acrylic, plastic, and ceramic artificial teeth, industrial production, are used. Resin acrylic teeth are more widely used nowadays because they have a lot of benefits. They have chemical connection with denture base, the technology of their production much easier. Modern acrylic teeth can be in different shades, they look like natural teeth, have increased strength, and of course they are much cheaper than porcelain, ceramic, teeth. In comparison with plastic teeth, porcelain slowly erased and much more color stable, better simulate the natural teeth. Plastic teeth without the risk of a split can ground off without any restrictions, and if necessary, built up fast hardening plastic. Artificial teeth used to replacement the dentition defects must meet certain requirements. They must be made from material having no harmful or irritating effects. Teeth should have the correct anatomical shape, Beautiful and varied coloring to make up as a lack of chewing function and aesthetic violations. The color of artificial teeth imitating natural transition, lighter color, translucent cutting edge to more intense and dark staining of the cervical area. Teeth should be color stability. Resistant to oral fluid. Teeth should not be destroyed by chewing pressure and be sufficiently resistant to abrasion. A strong bond with the denture basis material. Tooth material must be easily processed and not be porous. Thermal expansion of the tooth material should be more approached to the thermal expansion of the base material. In order to improve the quality of prosthetics, the album styles and types of plastic teeth have been done. The basis of the album is put rational system that allows the dentist to select the optimal size and type set of teeth for dentures. All styles of front teeth are 3 types: rectangular, square, wedge-shaped, triangular, and oval. Ovate, as indicated in the diagram, corresponds to the geometric signs. Look at this picture. Artificial teeth are produced in sets with different shapes and shades of the teeth. A dentist using a special shade guide carries out shade selection and appropriate size of the teeth depending on the patient's face shape, size and shape of alveolar ridge and remaining teeth. This information is sent to the dental technician. Dental technician during denture manufacturing provides arrangement and grinding of artificial teeth in accordance with size and shape of alveolar ridge, remaining teeth position and bite type of the patient. Artificial plastic teeth Estedent O2. Artificial plastic teeth Estedent O2 are designed for application in prosthodontics for manufacturing of removable denture constructions. Plastic teeth Estedent O2 are manufactured on base of cross-linked acrylic polymers. They have a fluorescent effect. Teeth put into partial denture look harmoniously near natured teeth in ultraviolet rays. Teeth Estedent O2 have a good chemical bonding with denture base. Like their natural prototype, teeth Estedent O2 have optimo-functional and cosmetic characteristics. Teeth Estedent O2 are manufactured in accordance with Vita scale and consist of 9 shades: A2, A3, A3.5, B2, B3, C2, C3, D2, D3. Do coloring scale Estedent O3 teeth comply with colors No 28, 32, 33, 34, 35, 36, 38, 40, 41. Packaging. Artificial plastic teeth Estedent O2 are manufactured in the following sets: 1 complete set, 1 6 anterior upper teeth, 1 6 anterior lower teeth, 1 8 masticatory upper teeth, 1 8 masticatory lower teeth. 4 complete sets, 4 6 anterior upper teeth, 4 6 anterior lower teeth, 4 8 masticatory upper teeth, 4 8 masticatory lower teeth. 1 container of anterior upper teeth, contains 20 sets per 6 teeth. 1 container of anterior lower teeth, contains 20 sets per 6 teeth. 4 containers of masticatory teeth, contains 40 sets per 16 teeth. 4 containers of complete teeth sets, contains 20 sets per 28 teeth. Styles. There are 13 molds of anterior upper teeth, 5 molds of anterior lower teeth, 5 molds of posterior teeth. Styles and types of artificial teeth. There are 13 molds of anterior upper teeth. Styles and types of artificial teeth. There are 5 molds of anterior lower teeth, 5 molds of posterior teeth. Styles and types of artificial teeth. This slide shows the correspondence table of the style and shape of the anterior upper teeth, anterior lower teeth and chewing teeth. Requirements for setting all the anterior and posterior teeth. All the teeth must be located in the middle of the alveolar ridge. Each tooth must have contact with the 2 antagonists, except the upper second molars and lower central incisors. The upper dentition should have a semi-elliptical shape and lower dentition, parabolic shape. The total number of artificial teeth in edentulous jaws dentures, 28. Requirements for the upper frontal teeth setting. The middle line between the central incisors should correspond to the midline of the face. With a smile to be seen next of the teeth, but not artificial gums, which confirms the correctness of establishing a laugh. In short lip, the frontal teeth should be ground to the natural gums, short bite anterior tooth setting. The upper teeth should be visible from the lips at the slightest opening of the mouth. That confirms the correctness of the clamping line between the upper and lower occlusal rollers. Canines have to stand in the field perpendicular from the wing of the nose to the upper dentition. The cutting edges plane of the incisors should be parallel to the pupillary line. The upper teeth should overlap the lower teeth, but the overlap should be minimized. The cutting edges of the central incisors and canines must lie in the same plane. Lateral incisors in another plane situated higher by 0.5 mm. Teeth setting requirements. For the upper posterior teeth setting, first premolar should touch the horizontal plane passing through the cutting edge of the central incisors, only buccal cusp. The palatine cusp should be 1 mm away from the horizontal plane. Second premolar should touch this plane by 2 cusps. First molar should touch the horizontal plane medial palatine cusp. The remaining cusps of the first molar and second molar cusps everything not related to this plane, and depart from it at a distance of 0.5 to 1.5 mm. Teeth setting requirements. For the lower teeth setting, the middle line between the lower central incisors should be located in the same plane with the upper middle line. All the lower teeth are set so that the lower dentition should be less than the upper dentition and all the lower teeth properly in contact with the upper teeth. Artificial teeth setting is not persecuted to restore the original shape of the natural dentition of the patient. Correct setting of artificial dentition improves the cosmetic and functional value of the denture. Compliance with these goals is the middle line, smile lines, lines canines, the line between the dentition. Improve the stability of the prosthesis is a minimum upper frontal teeth overlap by the lower, setting the teeth in the middle of the alveolar edge, creating a sagittal and transversal occlusal curves, the average height of posterior teeth cusps. The processing route of partial removable laminar denture manufacturing consists of clinical and laboratory steps. Clinical procedures. 1. Patient's examination. Diagnosis taking. Treatment plan preparation. Analysis of the indications and contraindications for orthopedic treatment by partial removable laminar dentures. Medical records filling. Impressions making. 2. Jaw relations recording and fixation. 3. Try-and procedures of partial removable laminar denture wax reproduction in patient's mouth. 4. Fitting partial removable laminar denture in patient's mouth. Hacking the occlusal articulation relationship of the jaws. Base of denture correction. Recommendations for the patient. Laboratory procedures. 1. Pouring gypsum models. Drawing of denture borders on the model. Wax baseplates with occlusal rims manufacturing. 2. Models fixation in articulator. Holding clasps manufacturing. Setting up denture teeth in wax rim. 3. Final designing of denture wax baseplate. Flasking. Replacement of waxed baseplate with acrylic resin. Acrylic resin polymerization. Dentures grinding and polishing. Gypsum models making. Drawing of dentures borders. Wax baseplate with occlusal rims construction. Plaster models are produced from an impression. Gypsum without accelerators are usually used for models making. After mixing of gypsum powder with water until smooth consistency, a small amount of the mixture is placed onto the protruding parts of the impression, palate area, vestibular fold. Then the portion of gypsum is placed in deep areas of impression, impressions of teeth and alveolar ridge, with light hand vibrate against the side of the mixing bowl to allow the material to fill the surface detail. To prevent bubble formation and in order to achieve an accurate surface reproduction, it is better to use a special vibrating table. Then the material is added until the impression is full, leaving a domed top. After that, impression is inverted onto a gypsum table matching with a portion of gypsum on the table, just before the initial set of gypsum. The impression tray should be parallel to the bench top and the base should be not more than 1,5 to 2 cm. The gypsum is then flattened with impression borders with plaster knife or plaster spatula. When the material has set, 50 to 70 minutes, the impression should be removed. After that, the periphery of the model is trimmed without damaging the vestibule in model. For one jaw partial removable laminar denture manufacturing, it is necessary to make 2 models. One model is used for partial removable laminar denture manufacturing, master cast, another one, to reproduce the teeth of opposite jaw. After plaster model is ready, the denture's borders are marked on it. Make a waxed baseplate with occlusion rims. To determine centric occlusion, it is necessary to make a waxed baseplate with occlusion rims. It is shown in the picture. For baseplate with occlusion rims production, a plate of baseplate wax is evenly heated over the burner flame on one side only. Softened plate is then placed with unheated surface on a plaster model, and with thumb it is pressed to a palatal surface of the model and to edentulous areas without overpressure, trying not to thin the wax. In upper jaw, waxed baseplate constructioning usually starts with the deepest areas of the hard palate, then transfers on alveolar ridge and finishes in vestibular surface with tightly pressing of the wax to vestibule. Make a waxed baseplate with occlusion rims. In lower jaw, waxed baseplate constructioning starts with lingual surface and finishes also on vestibular surface. The wax is trimmed according to the borders of partial removable laminar denture, which are marked on the model. To prevent deformation of the waxed baseplate, it is strengthened with wire. Aluminum wire is bended according to the shape of frontal and lateral areas of palatal surface, and then this wire is heated and inserted in waxed baseplate and covered with melted wax. Occlusal rims are made from the rolled softened plates of baseplate wax. For occlusal rims, a preformed occlusal rims can be used. The rims with width of 1 cm and height of 1 to 1.5 cm are placed in edentulous areas and sealed to the base with melted wax. The wax rims should be wider than the remaining teeth and on par with them. With hot wax knife, the surface of occlusal rims is then smoothened and bevels with 135 degrees and distal areas are formed. Models fixation in articulator, occludator. After determination of a central occlusion, models should be mounted on a special device that reproduces the movements of the mandible. For reproducing the movements of the mandible, special mechanical devices are used. There are several types of such devices. Occludators, they reproduce the mandible movements in vertical plane, opening and closing the mouth, and articulators, they reproduce lower jaw movements in multiple planes, opening and closing the mouth, mandible movements forward. Models are fixed in articulator or occludator with plaster of Paris, which fills the spaces between occludators, articulators, arms and models. This is shown in the figure. Wire-bended clasps constructioning. After gypsum has set, waxed baseplates with occlusal rims can be removed. Wire-bended clasp is bended with dental rounded pliers and orthodontic pliers according to tooth shape on the gypsum model. This is shown in the figure. At first, the end of the wire is rounded with rounded burr. With rounded pliers, make a loop, like shoulder. It should cover vestibular tooth surface in retentive quadrants with moving to supporting quadrant. After that, the second bend, the beginning of the body, is formed at proximal surface. The third bend forms a process at nearly 90 degrees to the second bend and directs the process along the edentulous alveolar ridge. Picture content. Processing route of 1. Shouldered wire bended clasp constructioning. 1. Standard clasp piece. 2. Bending of shoulder. 3. Bending of body. 4. Bending of process. Vienka Pekin, L.M. Demnor, 1985. Flasking and packing. Classification of plastics, according to the following features. 1. By the degree of rigidity. Hard, for bases of prostheses and their restoration. Soft, for boxing tires or as a soft lining under the hard base. 2. By the temperature polymerization, cold curing, hot curing. 3. By the presence of the dye, pink, colorless. Components of plastic. 1. Powder, polymethylmethacrylate, beads or granules. Initiator, benzoyl peroxide. Pigments, colorants. Opacifiers, titanium or zinc oxides. Plasticizer, dibutylphthalate. Synthetic fibers, nylon or acryl. 2. Liquid, monomer, methylmethacrylate. Inhibitor, hydroquinone. Cross-linking agent, ethylene glycol of dimethacrylic ether. Flasking and packing. Flasket is a device for the polymerization of plastics during manufacturing of the dentures and casting duplicate modules of the jaws. Flask components. 1. Lower part, base, with grooves. 2. Bottom of the base. 3. Upper part with protuberances. 4. Cover. Flasking and packing. Flasking methods. 1. Direct. 2. Indirect, or revere. 3. Combined. Plastic molding methods depending on the equipment used in the manufacture of removable prostheses. First. Compressive pressing method. Methods of plastering of gypsum models and flask modifications. Reverse method of plastering. At the base of the flask, only the plaster model remains. Artificial teeth move to the upper part of the flask. Immerse the model for a few minutes in the water. The gypsum mixed with water, the upper part of the flask is filled with it, and the base of the model is placed in it up to the artificial gum. After hardening, the gypsum is cut off at the level of the upper edge of the flask, and the waxed base with the teeth and artificial gum remains free of gypsum, rising above the edges of the flask. The upper part of the flask with the plastered model is placed in cold water. Then cover it with a base, remove the cover and fill the base of the flask with plaster in small portions, lightly tapping the table to remove air bubbles. The base of the flask is filled with plaster to the brim, the cover is applied tightly, and excess gypsum is removed. After that, the flask is placed in boiling water to soften the wax. The gypsum is smoothed at the level of the flask sides and after crystallization is placed in cold water for a few minutes to prevent the gypsum from joining the new portion. After pulling the upper part of the flask out of the water and shaking it, place the base of the flask on it and remove the lid. Knead the plaster and fill the base of the flask in small portions. After crystallization of the gypsum, the flask is immersed in boiling water to melt the wax for 7 to 10 minutes. The melting of wax from the flask can be judged by the appearance on the surface of the water of its traces. The flask is then removed, separated with a plaster knife and placed on a wax grid. Boiling water is poured over both ends of the obtained gypsum mold until complete removal of wax. In order to prevent the connection of plastic with gypsum of the obtained molds, they are covered with insulating varnish, Isocol, algoplin. Insulating varnish is applied evenly over the entire surface of the plaster module with a brush, avoiding the varnish on the artificial teeth. If there is excess insulating material, it is removed with a brush. Plastic molding methods depending on the equipment used in the manufacture of removable prostheses. Compressive pressing method. Methods of plastering of gypsum models and flask modifications. Direct method of plastering. The model, artificial teeth and clasps remain at the base of the flask. The model is separated from the articulator, cut its base so that the edge of the base of the flask is slightly above the level of artificial teeth. Some parts of the plaster teeth with clasps are cut to facilitate the shoulder of clasps plastering. Moisturize the model, knead the plaster, and fill the base of the flask. The model is immersed in a plaster base to the bottom of the flask. From the extruded gypsum, a roller is formed above the teeth, covering the vestibular surface, the cutting edges of the frontal teeth and the chewing surface of the posterior teeth. The palatal surface of the upper teeth and the lingual surface of the lower teeth are not covered with plaster. The plaster roller must be sufficiently strong, smooth, without undercuts. Clean the edge of the base of the flask from gypsum after it hardens. Immerse for a few minutes in cold water to isolate from another portion of gypsum. Impose the upper part of the flask without cover. It is filled with liquid plaster, constantly shaking the flask to prevent the formation of bubbles, and tightly closed with a cover. Excess gypsum is removed. Methods of plastering of gypsum models in flask. Plastic molding methods depending on the equipment used in the manufacture of removable prostheses. Compressive pressing method. Methods of plastering of gypsum models in flask. Modifications. Combined method. The plaster model and the front artificial teeth remain at the base of the flask, and the chewing teeth move to the upper part of the flask. The method is used in the placement of anterior teeth as in the short bite anterior tooth. The base of the flask is filled with plaster and the prepared plaster model is placed into it. The front teeth, placed without artificial gums, are covered with a plaster roller, as in the direct method, and the posterior teeth are not covered by gypsum, as in the reverse method of plastering. The base of the flask is placed in cold water, the upper part of the flask is applied without a cover, fill with liquid plaster and close the cover. After the plaster hardens, the wax is melted. Combined method. Disadvantages. 1. If the parts of the flask are not tightly connected, plastic is released, which can lead to an increase in the height of the bite due to an increase in the thickness of the basis of the prosthesis. 2. Artificial teeth move vertically relative to the prosthetic plane. 3. In case of violation of the occlusion, the resistance of the prosthesis to its chewing effectiveness deteriorates. 4. Deformation of the plaster mold may occur in violation of the contours of small parts of the prosthesis, the shape of the basis of the prosthesis is distorted. 5. If the polymerization mode of plastics is violated, porosities are formed, gas, the presence of monomer steam, granular, with a lack of monomer and compression porosity, due to insufficient pressure. At present, the compressive pressing method is considered to be outdated, which does not provide the required quality, and another method came to replace it, injection casting, in which the prepared material is introduced into a pre-closed flask through the injection channel. Plastic molding methods depending on the equipment used in the manufacture of removable prostheses. 2. Injection casting pressing method. The method allows reducing the content of monomer in the bases of prostheses. Injection casting pressing method, compared with compressive pressing method. Advantages. 1. All excess plastics remain in the casting channel. 2. The plaster formed does not experience a deforming effect. 3. The details of the base part of the prosthesis correspond exactly to the specified parameters. The most promising technologies of cold pressing, which are successfully used in European countries. Injection pressing method, Kolzer, Germany. Cold polymerization method, Vertex, Holland. Cold polymerization method, Drava, Germany. Stages of plastic polymerization. 1. Wet sand, granular. 2. Viscous, long and short stretching threads. 3. Paste-like. 4. Rubber-like. 5. Solid. Polymerization mode. The polymerization process is aimed at converting plastic from plastic to solid. Monomer is a polymer mixture. It can harden under normal conditions, at room temperature, but this will take considerable time. To speed up the polymerization process, it is necessary to increase the temperature. After pressing, 3000 psi, both parts of the flask are tightened with a special retainer, biagal. The flask is immersed in water at room temperature, and, gradually, within 45 to 60 minutes, the temperature increases to 80 degrees Celsius. Then, from 80 degrees to 100 degrees, for the next 45 minutes. At the same time, as the temperature increases to 680 degrees Celsius, the polymerization process proceeds smoothly. At temperatures above 65 degrees Celsius, the residual benzoyl peroxide quickly splits and the polymerization rate increases. During this period, Due to the polymerization of the monomer, the mass decreases in volume. When reaching 65 to 68 degrees Celsius, the mass begins to increase in volume due to thermal expansion. Polymerization is a chain radical process, and an increase in temperature leads to an increase in the molecular weight of the polymer. This may lead to changes in physicochemical properties of plastic, strength, etc. Therefore, in order to achieve optimum molecular weight, the final stage of polymerization is carried out at a temperature of 100 degrees Celsius, maintaining exactly 30 to 45 minutes. Then the heating is turned off and the flask is in the water until it cools completely, slow cooling, for 40 to 60 minutes. Porosity of plastics. 1. Gas porosity. It is caused by the evaporation of the monomer inside the polymerization molding composition. This happens in violation of the mode of polymerization. When lowering the flask into boiling water. When heating a form with a large amount of mass due to the complexity of removing excess heat from it, which develops as a result of the exothermicity of the polymerization process, observed in the thick plastic base. Porosity of plastics. 2. Porosity of compression. Occurs with insufficient pressure, when the mass is formed, as a result of which separate parts of the form are filled with the molding material and voids are formed, usually observed in the terminal, thin parts of the product and between artificial teeth. Porosity of plastics. 3. Granular porosity. It occurs as a result of a lack of monomer in those areas where it can evaporate. Most often, the monomer volatilizes from an open vessel, where the plastic dough matures, or when it is in check. Looks like chalk streaks or spots. Acknowledgements. A special thank you to the free text-to-speech for U.S. English language ttfmp3.com. Thank you for your attention. Yours sincerely, the Associate Professor, M.D., Ph.D., EDM, Vyacheslav Tamilan.